Every 40 seconds, somewhere on this planet, a brain is being destroyed. Right now. While you sit here watching this, a clot is cutting off blood flow inside someone's skull. They do not know it yet, neither do the people sitting closest to them. Here is the part that should make you stop completely. In most cases, the brain tried to warn them days before, sometimes hours before. Specific, unmistakable signals that the body sent out like flares, and the person had absolutely no idea what they were looking at, because nobody ever taught them. If you are over 50, if you have high blood pressure, if your blood sugar has ever come back slightly elevated, if someone in your family has had a stroke, then the next 20 minutes may be the most important thing you watch all year. And I do not say that lightly. Before we go further, have you or someone you love ever had a brief episode of strange vision, sudden numbness that went away, or dizziness that lasted a few minutes and then disappeared? Type yes in the comments right now. Keep that experience front of mind, because by the end of this video, you are going to understand exactly what it was. Now, let me tell you something you almost certainly have never been told. Your doctor wants to explain all of this to you. I believe that sincerely. The problem is, the system gives your doctor an average of 7 minutes with you per visit. 7 minutes to review your medications, check your blood pressure reading, interpret your lab results, respond to your questions, document everything, and move on to the next patient. 7 minutes. There is no billing code for sitting across from a patient and teaching them to recognize the warning signs of stroke before it happens. The entire system is architected around treating people after the damage is done, not protecting them before. That is not your doctor's fault. That is a systemic failure, a gap that has existed for decades. And that gap, that education gap, is where people fall through every single day. People who would have acted differently if someone had just explained what to watch for. So today, let me show you what falls through that gap. But first, I need to introduce you to Margaret. She represents a pattern I have seen repeated dozens of times over the course of my practice. Margaret is 71 years old, a retired school teacher, sharp mind, careful person, someone who does not consider herself someone who ignores her health. She takes her blood pressure medication every single morning. She knows her cholesterol numbers. She gets her annual blood work done without being reminded. 3 weeks before she ended up in an emergency room, something strange happened while she was standing at her kitchen sink. She was washing the breakfast dishes, and for about 60 seconds, her left hand went completely numb. Not painful, just absent. Like someone had taken that hand and wrapped it in several inches of thick cotton wool. She flexed her fingers, shook her wrist, ran the hand under warm water, and then it was gone, just like that. She thought she must have been gripping the faucet handle too tightly, or maybe she slept on it funny. She did not call anyone. She did not write it down. Now here is what I need you to really understand before we go any further, because what I am about to explain changes how you see every strange symptom from this moment forward. Most people picture stroke as a clear before and after. You are fine, then you collapse. Then everything is different. But the biological reality of how stroke actually unfolds is completely different from that picture. And once you understand the actual mechanism, the way your body actually builds toward this event over years, you will never dismiss a strange physical episode the same way again. Here is what most doctors do not have time to explain in a 7-minute visit. Your brain weighs roughly 1.4 kilograms, just about 2% of your entire body weight. But this small organ is extraordinarily demanding. It consumes 20% of the oxygen you breathe with every single breath, 25% of the glucose circulating in your blood, every minute, without stopping, without taking a day off, without tolerating any interruption. Think about what that means. Cut the blood supply to your brain for even 4 minutes, and cells do not weaken. They die permanently. The window between a warning and an irreversible event is measured not in days, but in minutes. That is why stroke is a race against time in a way almost nothing else in medicine is. So how does a brain artery suddenly block? Here is where most people have the wrong picture. It almost never happens out of nowhere. Picture your carotid artery, the main highway running up through your neck to your brain. Think of it like a water pipe that has been quietly collecting a buildup on the inside wall for years. Quietly, invisibly. Every year, the opening gets slightly narrower. The inner lining gets slightly rougher. You cannot feel this happening. There are no symptoms, no warning lights, just slow, silent accumulation. Then one day something shifts. The pipe goes into a brief spasm, or a tiny fragment of that buildup breaks loose and travels upward. And for 30 seconds, maybe 5 minutes, blood flow to part of your brain drops to almost nothing. Like that clogged old pipe when the water pressure dips at night. Your brain glitches. You feel something. A symptom arrives. Then the spasm eases. The fragment drifts on. Blood flows again. The symptom disappears. And you feel relieved. You feel lucky. But here is the critical thing. You were not lucky. You were warned. That warning has a medical name. A transient ischemic attack. A TIA. Transient simply means temporary. It comes and it goes. But what it leaves behind is a countdown that has begun. Research published in Lancet Neurology, following over 10,000 patients after a TIA event, found that the risk of a full stroke within the following 48 hours is as high as 10%. 10% in just 48 hours. 10%. Let that sink in for a moment. That is not a footnote. That is an alarm going off at maximum volume. And the reason most people do not hear it is because nobody told them what an alarm sounds like. 4 days after the hand numbness in the kitchen, Margaret was sitting in her reading chair in the late afternoon. The house was quiet. She was reading a novel she had been working through slowly, and suddenly the words on the right side of the page disappeared. Not blurry, not harder to focus on. They were simply gone. As if someone had taken an eraser to the right half of everything in her field of vision. For about 90 seconds. She blinked, hard, rubbed her eyes with both hands, looked again at the page. The words were back. Every one of them. She sat very still for a moment. Then she told herself she needed to call her eye doctor and update her glasses prescription. She still did not call anyone that day. Now let me walk you through the 5 warning signs that your brain sends before a stroke. I want you to know right now, the one I am saving for last, number 1 on this list, is the one that catches people off guard the most. It is the warning that falls through the cracks more reliably than any other. Stay with me all the way through, because that final one is the one you are least likely to have heard before. The 5th warning sign, sudden loss of coordination, a drunk walk, and no alcohol was involved. You are on a flat floor, a surface you walk across every single day. And out of nowhere, your foot lands in the wrong place. Your leg feels strange, rubbery, like it belongs to someone else. You reach for the wall or grab the door frame to stop yourself from going down. Or you are hit by a violent spinning sensation so powerful and so sudden that you have to sit down immediately, even though you were perfectly still just a moment before. Now here is what is actually happening inside your body when this occurs. At the back of your skull, nestled underneath the larger brain hemispheres, sits a structure called the cerebellum. Small but critically important. Think of it as the navigation and balance system that runs continuously in the background. Every second you are upright and moving, your cerebellum is running thousands of microcalculations. Where is your center of gravity right now? How hard should the left calf fire compared to the right? How does the angle of the floor change the position of your hip? It coordinates all of this automatically, so you walk in a straight line without consciously thinking about any of it. The cerebellum gets its entire blood supply from arteries that travel up through the bones of your neck vertebrae, what doctors call the vertebro-basilar system. If blood flow in those arteries drops sharply, even for just a few seconds, the cerebellum essentially freezes mid-calculation. That is when you veer sideways on a flat floor, when your foot lands wrong, when the world starts spinning for no reason you can identify. Here is the crucial distinction most people miss. Benign dizziness almost always has an identifiable trigger. Rolling over too fast in bed, standing up suddenly from a seated position, turning your head quickly to one side, a known inner ear condition. But spontaneous, intense dizziness that arrives without any of those triggers, especially when it is accompanied by any difficulty walking a straight line, that is a different problem entirely. That is not an inner ear issue. That is your brain telling you something is happening upstream. Do not explain it away. The 4th warning sign, sudden speech breakdown. And let me be very precise about what I mean here, because this is an area where people consistently confuse a normal experience with a warning sign. Forgetting the right word when you are tired, struggling to recall a neighbor's name when you have just woken up, losing your train of thought mid-sentence. These things happen to everyone, and they are not the sign I am talking about. What I am talking about is something of an entirely different magnitude. Your words suddenly come out slurred, scrambled, disconnected in a way that you yourself can hear is wrong, or they simply refuse to come out at all. You have the thought completely formed inside your mind. You know exactly what you want to say, but between your brain and your mouth, the connection has broken. The words get stuck, or they come out in the wrong order, and you cannot stop it. Or the opposite happens. You speak fluently, easily. Sentences flow out without effort. But what you are saying makes no sense to anyone listening. And when someone speaks to you, their words do not resolve into meaning. Here is the biology behind both versions. Two separate and distinct speech centers live in most people's left hemisphere. The first, often called Broca's area, manages the motor program for speech. It sends precise instructions to your tongue, your lips, your jaw, your vocal cords, so they coordinate into recognizable words. When this area loses blood flow, even briefly, the mechanics of speech collapse. You understand everything, but producing speech becomes impossible or severely distorted. The second, often called Wernicke's area, manages comprehension and the organization of language itself. When this area is deprived of blood, fluent nonsense is the result. The person speaks easily but meaninglessly and cannot process what others are saying. Both of these areas can be briefly disrupted by a TIA. Both can produce symptoms that last only a few minutes. Both are unmistakable to the person experiencing them. And here is where the critical mistake happens. People think because the speech came back because it was only 2 minutes, because they felt fine afterward, it does not count. They file it under, I was just tired or I must have been distracted. It counted. Think of it this way. If the smoke alarm in your home goes off at 2 in the morning and then stops by itself after 90 seconds, you do not roll over and go back to sleep assuming it was a glitch. You get up, you find out what triggered it. The third warning sign, vision loss in one eye, not both eyes. 1. That distinction is important, and here is why. You are going about a perfectly ordinary moment, getting out of the car, walking toward a doorway, and suddenly one eye goes dark. A gray curtain drops across it, or a section of your visual field disappears entirely. Not blurry, not foggy, gone. For 30 seconds, maybe 60. Then it comes back. You blink a few times, you check whether the light in the room changed. You tell yourself you should probably book an eye appointment. Here is what most doctors do not have time to explain in that 7-minute visit. The artery that feeds your eye is not a random isolated structure. It is the ophthalmic artery, a direct branch of the internal carotid artery, the same carotid artery that supplies blood to your brain. They are on the same line. When a tiny clot or fragment of arterial plaque breaks free and travels upward through the carotid, it reaches a fork. One path leads to the eye artery. Another path leads to a brain artery. When the fragment takes the path to the eye artery, you get a brief blackout in one eye instead of a permanent stroke in the brain. The clot missed the brain by 2 millimeters, maybe 3. Neurologists have a Latin phrase for this symptom, amaurosis fugax, fleeting blindness. When a patient describes that experience in a clinical setting, evaluation does not wait. Because the medical records show a pattern over and over with near mechanical consistency. One eye blindness episode ignored, a second one explained away, a third attributed to something mundane. And then the fourth event is not in the eye, it is in the brain, and it is permanent. If this information is new to you, if you did not know these 5 warning signs before you sat down to watch this, hit like right now, because the algorithm needs a signal to show this to someone else who needs it. Someone who may be sitting with a symptom they do not understand. One tap changes that. The second warning sign, sudden numbness or tingling on one side of your body. One arm, one hand, half your face, the cheek or lip or tongue on one side, or one full side of your body, from shoulder down through the hip to the knee. It feels like pins and needles, like thick cotton packing around that limb, like the body part has temporarily stopped being yours, and it comes out of nowhere. You are not in an awkward sleeping position. You did not just cross your legs for an hour. You are sitting upright in a chair or standing in a queue or walking on a normal surface. And it starts. Now here is the key clinical detail. Stroke symptoms are almost always one-sided. And the reason for this tells you something important about the anatomy of the problem. Each hemisphere of your brain controls and receives sensation from the opposite side of your body. Your left hemisphere maps your right hand, your right face, your right leg. Your right hemisphere maps the left side. This is called contralateral organization. When one hemisphere loses blood flow, the symptoms appear on the opposite side, not both sides simultaneously. This is why bilateral, symmetric symptoms, both hands going numb at the same time and to the same degree, more often points toward a compressed disc in the neck or a whole body issue unrelated to stroke. But a sudden, unexplained, one-sided numbness that resolves on its own after a few minutes, that asymmetry is your body flagging a neurological event. Pay attention to which side. Write it down. That detail matters enormously in a clinical evaluation. Now here is where Margaret's story picks up again. When she finally came to see me, I went through her history carefully. The left-hand numbness at the sink. The visual disappearance in the chair 4 days later. 2 distinct presentations consistent with transient ischemic attacks. Different vascular distributions. Different timing. I ordered a carotid duplex ultrasound, not a standard ultrasound. The duplex version shows both the physical anatomy of the artery wall and the actual blood flow moving through it, including whether flow becomes turbulent and abnormally fast at a narrowed segment. The result came back showing her right internal carotid artery narrowed by 68%. Not quite at the threshold that typically triggers surgical conversation, but close enough to change the entire clinical picture. I also ordered a glycated hemoglobin test. Her result was 6.1%. Pre-diabetes, never diagnosed, never flagged, quietly damaging her vessel lining for an unknown number of years with no label attached to it. And I fitted her with a Holter monitor, a 24-hour continuous heart rhythm recording worn during her normal day, not a 10-second ECG in my office. Because a 10-second snapshot will miss everything that happens in the other 23 hours and 59 minutes. The Holter result changed everything. 3 separate episodes of atrial fibrillation were captured in that single day, each one a few minutes long, each one generating exactly the kind of chaotic, churning blood flow that forms clots in the upper chambers of the heart. Clots that can shoot directly from the heart to the brain. She had felt these episodes before. She had put them down to stress, to too much coffee, to getting older. 3 separate problems, each one independently elevating her risk. None of them on her radar, and none of them would have been identified in a standard 7-minute visit. And now, the warning sign that surprises people most, the one I held back. Number 1 on this list. It is not a single symptom. It is a pattern. And the pattern has 2 parts. The first part, a sudden severe headache that is unlike anything you have experienced before. One that reaches maximum intensity within 60 seconds of starting. Not a headache that builds over the course of a morning. One that is simply there, at full force, within 1 minute of onset. Research published in the New England Journal of Medicine describes this as a thunderclap headache. The comparison is deliberate. It arrives like a thunderclap. Sudden, maximal, impossible to ignore. This type of headache can signal a subarachnoid hemorrhage, bleeding around the brain from a ruptured vessel, and it is a medical emergency with no gray area. Emergency evaluation immediately, not after you see if the painkiller helps, immediately. But there is a second, more subtle version that matters just as much for stroke prevention. And this one is far easier to miss. A headache pattern that has changed character over the past several weeks. Not necessarily more painful, but different. Different location than your usual headaches. Different quality of pain, arriving at a different time of day, accompanied by sensations you have not had with headaches before, and occurring alongside any of the other warning signs on this list. That combination deserves urgent evaluation, not watching and waiting, not more painkillers. Now, I need to be completely direct with you about something. Most headaches are not strokes and are not warning signs of stroke. The majority of headaches come from muscle tension, dehydration, disrupted sleep, or arthritis in the small joints between the 2nd and 3rd neck vertebrae, which can send pain upward into the skull from below in a pattern that mimics a primary headache disorder. So I am absolutely not asking you to treat every headache as an emergency. I am asking you to notice change. A headache that does not fit your normal pattern. A headache that arrives differently than your headaches have ever arrived before. That change is the signal. And that signal, combined with any of the other 4 warning signs, is when you stop waiting and start acting. So now you know all 5. Let me quickly put them together. Brief vision loss in one eye, sudden one-sided numbness, unexplained loss of coordination or balance, sudden speech breakdown, and a headache that is different from all your other headaches, especially one that reaches full force within 60 seconds. Any one of these. Even if it resolved in 2 minutes, even if it happened a week ago, even if it only happened once, that is a reason to contact a doctor urgently and ask specifically about transient ischemic attack evaluation. Here is what matters most in the window that follows. Roughly 72 hours from the event where intervention can change what comes next. Do not drive yourself. A brief loss of vision or coordination while operating a vehicle is catastrophic, not just for you, but for everyone around you. Make the plan before you ever need it. Decide now who you would call. Decide now what number to dial. Having that plan takes 30 seconds. Not having it takes everything. Here is something I need to be completely clear about. Do not take blood thinners on your own. Not aspirin, not ibuprofen, not any anticoagulant medication based on something a family member suggested or an article you found online. Here is the reason this matters so much. There are two fundamentally different types of stroke. An ischemic stroke involves a blocked vessel. Blood cannot get through. A hemorrhagic stroke involves a bleeding vessel. Blood is going where it should not. Blood thinners can provide benefit in certain ischemic situations. In a hemorrhagic stroke, they accelerate the bleeding and can directly accelerate death. The only way to determine with certainty which type is occurring is brain imaging in a hospital setting. A CT scan. No one can determine this from symptoms alone. Not from the outside. Not from a description over the phone. Not even me, sitting across from a patient. If you are already taking a prescribed anticoagulant medication, whether warfarin, rivaroxaban, apixaban, or any other, carry a written list of that medication with you at all times. Emergency teams make different decisions depending on what anticoagulation is already on board. That information in your wallet has saved lives. One more thing about blood pressure in this window. If the top number, the systolic reading, reaches 180 or above, or the bottom number, the diastolic, reaches 110 or above, call emergency services. Do not take an extra blood pressure pill and check again in 30 minutes. That blood pressure level in the context of neurological symptoms is a crisis level reading. While you are waiting for help or traveling to care, lie flat. Legs elevated slightly above chest level if possible. This passively supports blood flow toward the brain without requiring the heart to work harder. Neutral neck position. Not sharply bent forward. Not thrown back. Keep the airway open and the neck vessels uncompressed. Avoid hot showers, alcohol, and cigarettes in this window. Sudden peripheral vasodilation in an already unstable circulatory picture can divert blood away from the brain at exactly the wrong moment. Write down every symptom you experienced with as much detail as you can remember. Which side, what exactly it felt like, how long it lasted, how it resolved. This information is diagnostic gold in an emergency evaluation and difficult to reconstruct accurately under stress. Margaret started her adjusted protocol the following week. New anticoagulation medication for the atrial fibrillation, blood pressure recalibration, and a genuine conversation about what prediabetes had been doing quietly to her vessel lining for years. Day 5, she sent me a message. She said the new medication was making her dizzy when she stood up from a chair. She felt unsteady on her feet in the morning. She wanted to know if she should stop. I told her exactly what I tell everyone in that situation. What you are feeling is the adjustment period. Your cardiovascular system has been operating at a certain set point for years. You are asking it to recalibrate to a new baseline. The dizziness when standing is your blood pressure adapting to the new medication. It is uncomfortable and it is temporary. Push through the first 2 weeks. If it becomes severe, call immediately. But mild unsteadiness in week 1 is not failure. It is physiology catching up. She pushed through. Now 3 tests. Write these down. Ask for them by name at your next doctor appointment. The first is carotid duplex ultrasound, not a standard ultrasound, the duplex version. It shows both the anatomical structure of your neck arteries and the blood flow dynamics moving through them, including whether there is turbulence and acceleration at a narrowed point. When a carotid artery is narrowed by more than 70% by plaque, that is what vascular surgeons call hemodynamically significant stenosis. The narrowing is severe enough to meaningfully impair blood flow under normal conditions. At that threshold, there is a surgical procedure called carotid endarterectomy, in which the plaque is physically removed from the inside of the artery. It is a routine vascular surgery in modern practice, and research shows it reduces subsequent stroke risk substantially in the right candidates. If you have risk factors, including high blood pressure, high blood sugar, a history of smoking, or any of the warning symptoms from this video, asking for a carotid duplex is a completely reasonable clinical request. The second test is glycated hemoglobin, HbA1c. This is a blood test that measures how much of your hemoglobin, the oxygen-carrying protein in your red blood cells, has had sugar molecules attached to it over the past 3 months. The higher your average blood sugar has been over that period, the higher this number will be. And critically, you cannot alter this result by eating carefully the day before your blood draw. It reflects 3 months, not one morning. The cutoffs are as follows. Under 5.7% is normal. Between 5.7 and 6.4 is prediabetes. 6.5% and above meets the diagnostic threshold for diabetes. Prediabetes means your blood sugar has been elevated enough for long enough to cause real damage to the inner lining of your blood vessels. That lining is called the endothelium. Think of it like the non-stick coating on the inside of a healthy pipe. When it is smooth and intact, nothing adheres to it. Blood flows through cleanly. When it is damaged by chronically elevated sugar, it becomes roughened, inflamed, porous. And those rough patches become the attachment points where cholesterol deposits and clots form and grow. This process starts years before anyone calls it diabetes. Most people with prediabetes do not know they have it. The symptom load is minimal. There is no clear moment when anything feels wrong. It just runs quietly in the background, degrading the very infrastructure that keeps your brain alive. If you have never had this test, or it has been more than 2 years since you had it, bring it up directly at your next appointment. The third test is Holter monitoring, a 24-hour continuous cardiac rhythm recording. The reason a short ECG in your doctor's office is not sufficient is straightforward. Atrial fibrillation, the rhythm abnormality most directly linked to stroke risk, is often intermittent. It may occur 3 times in a day for a few minutes each time. It may not occur at all on the day you happen to be in the clinic. A 10-second snapshot misses it entirely. The Holter device is a small unit worn on the body for a full day while you go about your normal routine, sleeping, walking, cooking, and it records every heartbeat. If atrial fibrillation is present and occurring, it will be captured. Here is why this matters so much. In atrial fibrillation, the upper chambers of the heart stop contracting in a coordinated rhythm. Instead of pumping, they quiver. Blood does not empty cleanly from these chambers. It pools and churns. And in churning blood, clots form with remarkable efficiency. Those clots can travel directly from the heart through the carotid arteries to the brain, what is called a cardioembolic stroke. And cardioembolic strokes tend to be severe. Many people with intermittent atrial fibrillation feel only occasional palpitations, brief flutters, or a sense that the heart skipped something. Many feel nothing at all. They blame the sensation on caffeine, stress, or aging. The Holter catches what the perception misses, and here is the number that matters. When atrial fibrillation is identified and treated with appropriate anticoagulation medication, monitored correctly in partnership with a cardiologist, stroke risk in that condition is reduced by 60 to 70%. 60 to 70%. That is not a marginal improvement. That is most of the risk addressed. Now I need to address medication specifically if this is relevant to you. Anticoagulants are powerful and they interact with other things. Warfarin in particular requires regular blood monitoring and is affected by changes in diet, especially foods high in vitamin K like leafy greens. It is also affected by many common medications including certain antibiotics, pain relievers, and supplements. Any change in your medications while on warfarin needs to pass through your prescribing doctor. Do not add, remove, or adjust anything without that conversation. The newer oral anticoagulants, often called NOACs, have a more predictable profile, but they also carry drug interaction considerations. The key point is this: these are not supplements. They are serious medications that require ongoing medical supervision. If your doctor puts you on one, make sure you understand the monitoring requirements before you leave the appointment. I want to be completely honest with you about what to expect when you begin making these changes, because the single most common reason people fail to follow through is that the first week feels worse than before they started. And when they feel worse, they assume it is not working, so they stop. At exactly the moment when the biology is actually beginning to shift. Week 1. Medication adjustments produce adaptation symptoms. Dizziness on standing, slight fatigue, more frequent urination if diuretics are involved. If dietary changes are made, digestive adjustment, these are normal. They are the body recalibrating to a new set point, not signs of failure. Week 2, the adaptation symptoms settle. Blood pressure readings begin showing more consistency. The variation narrows. You may notice small improvements in energy levels, in the quality of sleep, in mental clarity in the morning. Week 3, this is the week that most patients describe as the turning point. Something shifts. The protocol begins to feel like a routine rather than an effort. The numbers start moving in a direction that is visible and meaningful. Week 4 and beyond, lab results begin telling a different story. A1C trending downward. Blood pressure more consistently in range. The direction has changed. I have seen this timeline play out enough times to say with confidence, the people who get through week 1 become the people who prevent strokes. The people who stop at day 4 become a different kind of statistic. Most people quit at day 4, before any meaningful biological change has had time to occur. Do not be at day 4. 6 weeks after we started making adjustments, Margaret came in for a follow-up. Her HbA1c had come down from 6.1 to 5.8%, a meaningful reduction in that window of time. Her carotid narrowing was stable, not advancing. The rate of plaque growth appeared to have slowed. Her atrial fibrillation episodes had decreased significantly under anticoagulation therapy. Her cardiologist was pleased with the INR readings, and Margaret had started keeping a small blue notebook on her nightstand. Every morning, before anything else, she wrote down her blood pressure reading, the date, how she had slept, any symptoms overnight. Not because she was anxious, because she understood what the numbers meant now, because the numbers were no longer just data points. They were information about what was happening inside her body in real time. She told me something I come back to often. She said, I used to think I was healthy because nothing bad had happened yet. I now understand there is a very big difference between nothing bad having happened yet and actually being protected. That distinction between absence of events and active protection is what this entire video has been building toward. Today, you have learned something that takes years of clinical practice to translate into plain language. Stroke is not a lightning bolt from a clear sky. It is the predictable endpoint of a process that has been building for years, and it announces itself before it arrives. Now you know what that announcement sounds like. You know the 5 warning signs. Brief vision loss in one eye. Sudden one-sided numbness or tingling, unexplained coordination loss or intense spontaneous dizziness, sudden speech breakdown, and the headache that is different, especially one that hits maximum force within 60 seconds. You know about the 72-hour window. You know the 3 tests to ask for by name. You know the critical rule about blood thinners and why it exists. You know what week 1 feels like and why to push through it. And you know why the system never got around to teaching you any of this. Not because the information did not exist, because the 7-minute visit was never designed to hold it. Now act on it. If this video reached you today, share it with one person, your mother, your father, your husband, or wife. Not because it was interesting, because recognizing one of these warning signs instead of explaining it away is the difference between a near miss and an event you cannot reverse. Type I finished in the comments if you watched the whole way through. And write down the first test you are going to bring up at your next doctor appointment. Not because I need to see it, because writing it down makes it 3 times more likely that you will actually follow through. And your comment may be the thing that pushes someone else scrolling through the comments to do the same. Before you leave, there is something I did not cover today, something I am going to address next week that genuinely surprised me when I first encountered the research. There is a habit that the vast majority of people over 50 engage in every single morning without a second thought. Something that feels harmless, that nobody has ever told you to question. And new data suggests it may be quietly doubling vascular inflammation risk. Not occasionally. Every morning. That is next week. Do not miss it. Everything I shared today is for education and understanding. Your health is specific to you and to your current situation. Bring these warning signs, bring these test names to your own doctor. Use this as the foundation for a more informed conversation, not a replacement for one.